Weight maintenance is the actually hardest part. And, I'm very open about my own weight history with my own patients and just anybody that's asked me. I actually lost weight several times in my life the natural way. I exercise, I watch what I ate. I would lose like 20-30% of my total body weight. And I would keep it off for like a year or two. And then whenever I have a life disruptor, as I call it to my patients, I would regain the weight back and more.
Yeah. Welcome back to the Lead Lamp Podcast. It's Brett Wiley. I'm here with Dr. Caissa Troutman from Midlife reMDy. And I know we've talked a little bit before, and we had an introduction even before today of what you're into, but kind of give us a breakdown of, what you do and a little bit about your company, what you're into today.
Yeah. Well, first off, thanks so much for having me. It's my pleasure to be here and really spreading the word of women's health. So my name is Dr. Caissa Troutman. I'm a quadruple board certified physician. I specialize in obesity medicine, culinary medicine, and a Menopause Society certified physician. So I always talk about those certifications are my research.
Okay.
It's research. I did all of that. I went through all of that because I was trying to help myself. I am a woman with obesity, and I'm a woman in perimenopause. So all of that led to me turning my, personal pain into professional expertise.
You were trying to discover
how to help myself,
how to help yourself, and about yourself, like kind of doing a deep dive. And then that you went down the path of just like, I'm sure like, well, how can I figure it out for me and to help other people? Exactly.
I think for midlife women, a lot of us, so again, my specialty is metabolic health and weight, as well as helping women with FDA-approved hormone therapy in the form of estrogen, progesterone, and testosterone. And very frequently, midlife women, even though we're amazing at a lot of things, career, managing our life, our family schedule, very often we're not very good at prioritizing ourselves and our health, and that tends to suffer. So that is really who I want to help and who I've been helping all this time. Okay. And it's such a fun journey.
What were you doing before you took that step?
Yeah, such a long. How many minutes do we have?
So I've been minutes version. You'll do.
I've been practicing for like 20 something years as a physician. I first was a primary care physician. I got burned out, and I did urgent care for a couple of years, and I got burned out. Yeah. And then it was around that time. I think I was in my early 30s where I just felt like medicine is rough. It's a hard job.
It's very demanding.
Yes. Yeah. And we put a lot of our kind of personal life into it. But so in that burnout time, I was also at my heaviest weight. I'm 5 foot, so I'm not very tall. So at that point, at my heaviest, and I was just like, honestly, frustrated with myself. I told myself like, I'm supposed to be a smart person. I'm supposed to be, a driven, and I am, but why is it so hard to lose weight? So that's kind of when I deep dove into like the science, discovered what the science of obesity medicine and modern science is. And and the truth is really, and this is what I tell my patients, it wasn't my fault. The reason it's hard to lose weight, it's not just because of we just don't use the calorie in, calorie out model. It is a complicated orchestra of our genetics, our habits, our hormones. And actually, I in my practice to my patients, I call it the 3 H's. Okay. So it's hormones. These are the 3 health handbrakes, which are hormones, habits, and headspace. Okay. And hormones isn't just estrogen, progesterone, and testosterone. Actually, it's actually the metabolic hormones I talk about is like insulin, cortisol, ghrelin, and leptin, which we can go into further detail if you want. But there's so many things that make it harder for us to lose weight. And that's what I try and help my patients understand is like eating less and moving more is not the metric that we use.
Right. And that gets pounded into your heads.
Oh my God.
So much from everything you see, commercials, there's this app for this or whatever. And you're trained to just, I got to eat less and exercise more.
Right.
And then I'm sure you get a lot of people that come in that are very frustrated and they're like, I'm doing these things.
Exactly.
And like, I'm sure they say like, I've tracked it. I can see, here's what I'm doing. Why is it not working?
Right.
And there's so much under the covers that you're like, well, hang on, we gotta kind of peel the onion a little bit and say like,
100%.
there's more to it than that.
100%. And I think, the calorie in, calorie out model is such, it sounds so mathematically correct, right? It's a nice, neat bow.
I was to say it's clean. Like it's easy to figure out.
Exactly. Very scientific. But, but the thing is, there's genetics involved. There's so many how we sleep, how we move our body, and I never say that that's not the answer. It's just one part of the picture.
Yeah, it's a piece.
Exactly.
And I'm sure you can have everything else right, and if you have that wrong, it's still not going to work. Right. You have to have all the things together.
Exactly. Which is why when we are trying our very best and counting calories and exercising and we're not losing weight, my patients end up feeling broken. And you have that sort of like negative feeling about yourself, self-confidence, self-esteem. And I tell them like, it's not your fault. It really isn't.
Right.
And there's truly a way. There's a science-backed, comprehensive approach to losing weight for the last time.
Nice. And it's probably also something that's frustrating because they see there are some people that do get it quick and it just clicks. But then there's a large number of people, like probably more people, that it doesn't click for, but they're not the ones that, the people that get highlighted of successful stories of it might have already had the other two pieces of we'll call it the pie pieces. They already had the other pieces kind of more figured out. And it was that last, calorie in, calorie out. Right. But like you said, they're doing what they're told to do, but they're not realizing that there's these other two pieces kind of behind the curtain where you have to show them that. And I'm sure once they start to realize and see it slowly starting to work, it starts to snowball too, right? Like once they understand the other two parts, as you were saying, like it probably clicks eventually and it starts to compound.
Yeah, and again, so the study of weight loss has been around for a long time. It's not like the first time we're studying weight.
No, it's not new. Yeah.
Right. So what the studies have shown really is there are a certain percentage of patients that can lose weight with just the calorie in, calorie out model. So like 5% of the population can do that, and they will not regain their weight back. So what do we say to the 95% of the population?
We'll just do what they're doing. Right. Well, that's what they typically do.
So we use that metric of, well, this 5% of the population was able to lose weight by eating less, moving more. So we now say that the rest of the population should do that. But again, and we can see that in randomized controlled trials, like, patients that were put on a medication, for example, on arm 1 and arm 2 is a patient that was not put on medication. But both arms were given nutritional advice. They were given, advice on exercise. They were given all the tools that would help. And there are some patients that do lose weight on that arm, but there's a lot more patients that lose weight on the other arm when you give them the tools that they need biological wise. But we digress. I mean, we can talk about all of that. Yeah. And it's again, I think if you lose weight the natural way, amazing. Like good for you. You rock it. You're the 5% of the population. But there's 95% of us that,
that need there's something else, whether it's medication or it's just you have to figure something else out. Like you said, your headspace might even be part of the problem. Like you have something else that you have to figure out about yourself to encourage you to not just lose it, but you said there was a key part there is they keep it off.
Yes.
Like it doesn't come back. So that's the other part of the battle too.
Yeah. Weight maintenance is the actually hardest part. And, I'm very open about my own weight history with my own patients and just anybody that's asked me. I actually lost weight several times in my life the natural way. I exercise. I watched what I ate. I would lose like 20-30% of my total body weight. And I would keep it off for like a year or two. And then whenever I have a life disruptor, as I call it to my patients, I would regain the weight back and more.
Yeah. And that's not hard because everyone's gonna have a life disruptor.
Yeah.
So
and that's in the form of like changing a job, having kids, changing location. I mean, anything, right? Going on vacation. Like that's a huge life disruptor that gets you off your routine, so to speak. So So
Okay.
yeah, that's the modern science of weight. It's not just that. There's a lot more to it.
Yeah, and I'm sure in 5 years there'll be another thing that we've discovered that helps even more people.
Yeah.
It's just not.
Yeah.
It's just yet to be discovered. And the more they research it, and that's with any of these things, like even the midlife stuff that we're going to talk about.
Yeah.
Like the more and more we research, the more we know, and the more you talk about it, the more people start to learn, and there'll be more that people discover of all these topics.
Yeah, and what's fascinating with the hormone, if you want to kind of switch over to that part, is that the data is there. The information that's disseminated to society or it is just the wrong information, or the how do I say it? The incorrect information. So for example, like the myth that estrogen causes breast cancer is still so pervasive, like that people think, oh, you're giving me estrogen, this is breast cancer.
I've not even I have no need to take that, but I've even heard that myth. Like I've heard it.
Yes, it's such a myth. That so this statement really originated from this study back in 2002 called the Women's Health Initiative study, and in that study they highlighted a point which they said like estrogen causes breast cancer. Mm-hmm. But if you look at the actual data, and I don't know how deep you want me to go into this.
You can go wherever you want.
So they announced that estrogen. So let me explain it. So first of all, they had two arms in that study. Mm-hmm. One arm that was patients on estrogen and progesterone.
Okay.
And then another arm with patients just on estrogen alone. So they stopped the study after 5 years. The estrogen plus progesterone arm, they stopped it after 5 years, and they said there was a 27% increased risk of breast cancer. Air quotes, by the way, of 27% increase. So of course you hear 27%, you're going to think like, oh my God.
Almost a third of the people.
Yeah, I'm like, so that is literally what happened. Everybody stopped taking their hormone therapy, et cetera, et cetera. But if you actually look at the data, so that 27% increased risk is called a relative risk.
Okay.
But if you actually look at the data, which we call absolute risk reduction, it was from 4 in 1,000 women over 5 years. The risk went up to 5 in 1,000 women in 5 years. So it's actually 1 out of 1,000 women in 5 years had technically the increased risk of breast cancer in that arm. Okay. So, and again, we're not minimizing breast cancer, right? It's just that the statistic, it's not 27% is what the point is there.
Yeah. When you're glossing over that statistic quickly, it's a scary big number.
100%.
But when you go deeper into it, you realize it's a more of a marginal move, not to, like you said, not to minimize the effects of breast cancer, but in that study, in that clinical application, it's not as big as what it sounded like initially.
And what they end up seeing too was actually it wasn't the estrogen that was the culprit; it was the old progesterone called medroxyprogesterone acetate. So in the one arm, which was just the estrogen alone arm, there was actually a 20% breast cancer reduction. So estrogen is actually protective.
So don't mind me asking, this is going to hopefully doesn't derail it, but in what, and this probably sounds, you're probably going to laugh about this, but like in what context would that be given to someone in midlife, therapy? Yeah. That way I can understand like why they were even studying that in the first place.
Absolutely. I mean, so I think in general, so hormone therapy, I mean, one thing that I probably want to just clarify is just not all hormones are the same. People will just think that hormones, like for example, when they think of estrogen, they think estrogen in birth control is the same as estrogen in hormone therapy, which is absolutely not different. The same. Okay. Totally different. So that's why a lot of patients come to me and said, well, I was told I can't have estrogen hormones because of, I don't know, I have migraines.
Okay.
So it's true that if you are older and you would not be an ideal candidate for birth control if you have migraines, but it doesn't mean you can't have it if you use hormone therapy. So there's just different levels and different types. So going back to answering your question, so technically hormone therapy is FDA approved to help only with 3 reasons. That is prevention of osteoporosis, severe hot flashes, and something called genitourinary syndrome of menopause. So just to kind of talk about that, so number 1, hot flashes. What's interesting is they have to put in the severe
Okay.
It has to be like severe hot flashes.
But how do you quantify that?
Well, there are ways to quantify it. But if you just kind of turn it around for men for a little bit, like, should we ask men with erectile dysfunction how severe their erectile how severe is it how often does it happen that you're not getting an erection, and this is why the treatment? I mean, isn't that kind of interesting?
You turn the tables and it's different. Yeah.
Yeah. So, so again, there's a little bit of how women have just really been treated differently when it comes to treatment of medical conditions. So those are the 3 FDA approved, but we can use it off-label. Let me rephrase that. I prescribe it as a physician trained to do this. I prescribe it off-label for women that are going through symptoms that are not those 3, but still experience symptoms from perimenopause, like anxiety, brain fog, joint pains, and so on and so forth. And off-label prescribing is something we usually do in medicine. Okay. So, for example, birth control is supposed to be for preventing pregnancy, right? But you see it prescribed for acne. You see it prescribed for regulating period, not for birth control. But so off-label prescribing is very common in medicine.
Yeah, and it's almost like there was a initial cause for that medicine to be created or prescribed, but then there's other benefits they realize
along the way
through the period that it's been clinically prescribed for one thing, that it takes acne away, or it helps with other issues. Yeah.
So that's what off-label prescribing is. Off-label simply means they didn't do randomized controlled testing, which costs millions of billions of dollars to do.
It doesn't mean you're going rogue and just and prescribing it for everything. It's just now we've realized there's other uses for it and other benefits, and you're using it
100%. So it's very often in my practice that my women come to me and say, "Oh my God, like my brain is not working. Like their work is suffering. They're unable to
they just have a foggy
or other things. I've never been this short-tempered with my family, and I'm just like have a short fuse. I'm yelling at my kids. I'm yelling at my husband, or like my joints hurt. I never used to have so much joint pain, or depression. I have one the other week that's just like, I never have depression, and I literally am just like sad and unmotivated to do anything. Or headaches. I have one patient that I always get a headache, the 3 days before my period, and it devastates me. I have to be in a dark room. I have to take meds.
Almost like severe migraines.
Yeah. I mean, it's very different symptoms.
And those are things that are these women that aren't, maybe they don't think they are, but they're not in full, like they're not in menopause yet.
Oh yeah. So maybe let's do some
let's back up on that.
Yeah. So menopause officially is the day, 12 months, the day where you haven't had a menstrual cycle for a year, right? So literally that is when we know that the ovaries are not producing estrogen anymore. So the years after that one day is what we call post-menopause. Okay. But the years before that is perimenopause. So people always think perimenopause is an old person thing. But actually, the average age of menopause is 52. The average age of perimenopause is 47. And perimenopause can start as early as 35.
Okay.
35. Like at 35, I was, I still had young kids, and I was stressed and overwhelmed and all those things. So how can, it's so hard to...
Yeah, you don't think of, at that age, I mean, that's kind of the age my wife and I are at. Like, you don't think that that's
perimenopause
upcoming. And you just think it's just life stress, or it's just, I've been really busy at work and I'm just exhausted and getting headaches, or you don't piece that together. And not that to say that that's what it is, but it's on the horizon. Like it could be sooner for some people than others.
The differential is how it is. Like very, it should be in the thought process if it's something that's affecting quality of life.
Yeah. And it's probably something when you're a little bit on the younger side of that scale to keep an eye on.
Yeah.
But not to like self-diagnose and say, well, that's what it is. Like you need to probably track it a little bit to kind of figure out patterns with it.
Absolutely.
When it's that early too.
Yeah, absolutely. I think symptom assessment is so perimenopause is not a diagnosis done with lab work. Perimenopause is a diagnosis done with it's a clinical diagnosis.
Yeah.
So it takes time to listen.
Gotta watch it.
Exactly. Listen to a patient. Try to see if the symptoms that they're sharing could be from low estrogen, high estrogen, low progesterone, et cetera. Because nobody will come into a doctor's office and say, I have perimenopause. Like, no. So and usually what they'll say is, I'm depressed. I'm having joint pain. My headaches are really bad. I'm short fused.
And I never had these things before.
Yeah. Or maybe they did and it's worse.
Okay, yeah.
So
now it's exacerbated by these.
ADHD since 20, now in my 30s, 40s, the same dose is not working anymore.
Okay.
It's the brain fog. So yeah, and how many minutes do we have in a doctor's office appointment? I don't know how.
I mean,
I don't know about you, but right?
Not many,
not many, right?
Yeah.
So how to put that in, right? Put that in that 5, 10, 15-minute appointment. It's not easy to tease that out.
Yeah,
right? So,
especially when you're just going to a primary care provider.
Right.
And not to knock our primary care providers. Yeah. I mean, you were there as well, but there's so much happening that they're also focusing on everything else to try to identify every issue or screen issues. When you're not specializing in that one thing, where you can dedicate a little bit more time to that now, like talking with the patient a little bit longer about that. And I'm sure now that you've transferred into this realm versus being a primary care provider, like you're able to sit with the person a little bit longer and talk about it. Yeah.
Oh my God, props to PCPs, man, because that job is hard, especially if you are in the system where you're told to see X number of patients, X number of time. Right?
Without naming those systems, the big systems that are popping up all across the country, regional medical facilities, they have numbers they have to hit. They are providing care, but they're also running a large business as well. So there's metrics involved that they don't have the liberties or luxury to focus on it like you do.
Physicians won't have that luxury to insist on how many minutes they want.
Unless you're extremely specialized within that system, which is rare.
Right.
Majority of them, it's a revolving door of patients. Yeah.
And which is kind of why I decided to open my own practice, so I could practice medicine in my own terms. The best way I think I can help patients, both in weight and in hormone therapy.
When did you make that switch? Like when were you like, I'm doing it, I'm going to make my own, we're going to go on my own? Yeah.
I mean, so my practice officially opened in September of, 23.
Okay.
25. Yeah. So it's like a year and a half-ish now. And honestly, it was I would say years in the making. Like, it's not like I just like, oh my God, let's go open,
You didn't wake up, your head pops off the pillow one day.
I think it was just a year, dissatisfaction creeping up in the loss of autonomy as a physician, meaning loss of autonomy, meaning I want to do it this way, but in the sense that I feel is best for the patient. And sometimes that's met with resistance because, again, it's a different perspective.
They have a formula. That they want to work. And that's what they do. Yeah.
Right. And again, burnout is a big deal. And I wanted to forge a path for myself where I can be there for my family and still help people the best way I know how, but also taking care of me.
Yeah.
Because a better me means a better physician to my patients.
Yeah. And a better,
impact to the world.
Better impact in general, not just that, but to your family, to everyone.
Yeah.
So when you're back at home, it's better. So I'm sure mentally too is a lot more freeing. Now, I mean, you have other things you have to worry about with your own business.
It's a different hard, I call it.
Yeah.
Both are hard. It's just a different hard.
Because now you're supporting yourself. Like, you're the one in charge of your own destiny with this, which is good. But then it comes to, like you said, with its own other challenges.
Yes. There's a lot of, like we were chatting about that earlier, like entrepreneurship is not for everyone. And I think it's very challenging, but I think just having the mindset of like, this will work out and, there's a plan.
And there is excitement along the way with it where you start to see cracks of like, oh, what's in there? Like, what can I do with that?
Yeah.
And you have the freedom to decide, I'm going to go in there and figure out, I picture like a little crack in the wall and you see some light coming through it.
Yeah.
This is a drawn out metaphor for this. I'm sorry. But like you see an opportunity, it might only look this big right now, but you can decide like, I want to figure that out.
Right.
And it becomes big.
Right.
Or maybe it doesn't, but you went there and you learned.
Right.
Whereas when you're in a bigger, more corporate setting, we'll call it, even in medicine, like you might not have the freedom to go down there and figure out if that's for you.
Yeah. And that's exactly why my practice originally is called weight reMDy, because initially I just wanted to focus on weight loss because an obesity medicine physician.
So that came first.
That was the first baby, yes.
Okay.
And then I, as you know, in business, right? Well, at least from my perspective as a newbie, like I then honed in on what I really wanted. So I pivoted a little bit and just decided to focus on midlife. You know, that's why it's called Midlife reMDy. Because I am them.
Yeah. No. And we were talking before we started, recording here, the impact on that, like you were saying, you do the exercise where you have people raise their hands and you're like, well, who's affected by, menopause or perimenopause? And you get some entertainment out of the people who either don't raise their hands because they don't think they're affected. Like before we talked about this, I would probably raise my hand and saying like, well, I'm not affected by that.
So
like,
I'm a guy, right?
Yeah,
So
I'm not going to go through that.
Yeah.
But, I have my wife and two girls in my house and plenty of, my mom's always around. And when you think about it, it will affect me at some point, whether it's, changing something that we have to deal with or just, someone's not feeling well that day or whatever, it will affect me. So I'm interested in hearing what, from my side of it, like how I could support people that are going through that as well. Cause like eventually my wife's going to probably go through that and I'm going to either figure out a way to, support them through that or, I could just get frustrated and walk away from the situation.
I think that's a great question, right? I think so again, that statement is perimenopause and menopause will affect 100% of women, 100%. Not every woman might be a mom, not everyone, but everyone will go through perimenopause and menopause, right? I think the first thing is validating that this is what's happening and not just it's their fault or they're just being I can't deal with that right now. Like they're just being hard to deal with. Like no, there's something else going on there. Yeah. And I'll tell you one of the common concerns that I think definitely, it will affect guys. Any symptom will affect a male partner, right? Depression, anxiety and stuff. But one that also frequently happens in perimenopause, menopause is decreased libido. So I think in the marriage, just recognizing like, okay, maybe this is not against me. This is not because my wife doesn't want me or whatever. It's because she's going through something.
Yeah. Well, and the husband or male partner in that relationship will also be going through their own changes, but at different timelines. So it's also like a hit or miss on when they both go through those changes.
Right. And the reason why midlife is so much harder is, yes, you have the hormonal changes of up and down. You have, some people are at the peak of their careers. So there's a lot more demands on their time, a lot more demands on their energy. Kids are also growing
They're aging out of the house.
Or it's so much pressure, so much societal pressure.
Yeah, I think it's a point in life where, I'm not there yet. Hopefully I have a few more years, but I've even thought about it now where I'm like, well, I'm not far from it. Like, my birthday's in a few days. I think about how I'm getting a little bit older, but I think every year you get a little older, you start, especially in my shoes, I start to think like, I'm not too far away from like a lot more big changes coming in my life. Like kids are going to be driving, are going to be moving out of the house. And there's a lot of stress that just comes with those things. And then you pile this on top of it.
Yes.
And it can be
just so much.
It's a strain on both sides of a relationship too.
Yeah.
Yeah.
Yeah. And it's interesting. They've actually called perimenopause, the transition years, is actually the window of vulnerability. So depression and anxiety is so high in this time frame, again, because of those things we talked about, right?
Yeah.
The life stressors and obligations, and throw in the hormonal chaos of perimenopause. A lot high statistics of depression, anxiety, and suicide this time frame. So it's not just about hot flashes. And, it literally is something that affects quality of life.
Yeah, it's not only my wife kept me up all night because she was over here tossing and turning and uncomfortable or whatever. It's there's a deeper
right. The joke is always like the hot flash on the cartoons, right? Yeah. The woman standing in front of the refrigerator.
It's like the commercial, like the over dramatic commercial of whatever the symptom is, and the TV does a good job at making it more dramatic, but it is a real issue.
Yeah.
Now let's dive into what you do when you have a patient that comes in and expresses any myriad of these symptoms. So it could be anything. We don't have to go into symptoms specific.
Right. Yeah.
But like, what's your process with them? Whether they're a little bit older, maybe they already are through menopause. I'm sure you get people who are post-menopause that still come in with problems, or younger people who are coming in and they think there's something going on. They just aren't sure yet.
Yeah.
What's your process?
Yeah. So I always talk about, I think every individual needs an individual risk-benefit discussion. That's it. So that's what I do with every initial consult with my patients is, what's your risk? What's your benefit? What can you get health-wise? What are the minor risks that's involved? And again, that's a very nuanced discussion.
Yeah, and person A from person B is going to have a completely different experience.
100%. And then the other is just honestly validating their symptoms. Because so many, I had one the other week that said oh, my husband doesn't really care. I'm like, well, it's okay, but I care. So it's funny how when you validate someone's symptoms as not just, let me rephrase that, maybe it's not valid, but just helping them see that their symptoms are actually based on a biological reason, and not that they're crazy.
They're not just losing their mind.
Correct.
Yeah, right.
Or not that they're just that they should try harder. Oh my God, I hear that, so I should just try harder. Even just for weight, right? I should just try harder. I should have more willpower, or I should just do more, be more, all that more. Sometimes well,
and that's going to only, I'm sure in both situations, that's only going to cause more stress,
more pressure,
and more burnout, 100%. Whatever program they're following, whether it's for weight loss or for midlife. You're going to have, anytime you can layer on more stress, it's just, people are going to burn out from that program more.
Right. Yeah. So
you're trying to keep that away.
Yeah, but validation and just and that's kind of why with my initial consults are all 1 hour, because I take time to explain the why.
Got it.
Because when you I firmly believe we understand the why, then we can tie in behavior change, or why we're doing this medication, or why we're not doing this, whatever it is. So, and I think women are smart. If we explain and show the data and the evidence, then they can make the decision that is best for them, versus us as a society telling women, you can't have this, you can't have that,
right?
Because of XYZ.
Right. Yeah. And them knowing there is a way, we just got to figure out.
It really is.
What do I need? Yeah.
Yes. It's, and again, it's biological. We are not broken. Very frequently women feel that way. Again, when I say I should do more, I should the more, and there must be something wrong with me because I'm not losing weight. There must be something wrong with me because I'm up at night at 2 a.m. can't go back to sleep. No. Yeah. So
now, not to go off track from the midlife stuff, but the weight side of it, your weight management, that you see patients. You see male and female patients.
I do.
You'll see anyone
male
for
patients.
that.
Yeah. Frequently, it's the husband of the wife.
Okay. They come back and they're like, oh, I'm going to bring my husband in.
Yeah.
now.
So
okay.
So I actually see.
I mean, that's good because then
right.
you were successful. And they brought their spouse back in.
Yeah, and actually it's easier for them as a husband and wife team to lose weight together.
Oh, I'm sure.
Partnership and stuff. Yeah, so I do see just patients for their hormone alone. I see just patients just for their weight alone. But I really believe, and I call it the up level midlife, is when you do tackle both at the same
Combine
time.
it.
Yeah, like helping women feel better so that when they feel better, then they can kind of focus with hormone therapy, with FDA-approved hormone therapy. And when they feel better means I'm sleeping now, I have more energy, my joints don't hurt. Then they can do the lifestyle changes that we know helps them, right?
Well, and I'm sure if you're working with them to be able to remove some weight, it also makes symptoms when they're going through perimenopause a lot different as well. You know, not that it's easier, but I'm sure some of those things go hand in hand just on comfort level.
100%. Yeah. Like, I mean, an example, I saw a patient last week. She said that, so I saw her for her follow-up and she was feeling fantastic. And she said like, I just thought I was lazy. This is a woman that runs a business. You know, she's like amazing human being who's loved by everybody. And I mean, and like, I was like, why are you saying that you're lazy? Like you are not lazy. And then I had started her on estrogen and then she was feeling better. And like now she was doing more things that she wasn't doing before. So it's very, you know, again, when we rewrite that narrative as I'm broken to, hey, maybe it's my hormones and let's see if this helps. And they feel better. Then, oh my God, she was just walking and doing all the things that I've asked her to do, you know, so it's very interesting.
Do you ever see any misconceptions with when you bring up like hormone therapy? Like, do you ever see people that are like, no, like, I don't know about that. And then they have just this thing in their head where it's not what they need, but then you talk to them about that and it's like, no, it's not what you think. Like it's a little bit different than like, kind of like what you were talking about with the headaches. Like, oh, I can't take estrogen because I get severe headaches. They just told me I couldn't ever do that. So do you see that pretty commonly where there's misconceptions with what they hear and you're like, no, it's not that at all. This is actually what it does.
Yes, 100%. And one of the things I do too in my non-existent spare time, just kidding, is I talk on podcasts. I really try and spread the message of the myths and misconceptions of hormone therapy. Anybody that's interested in becoming my patient, I do a free video meet and greet with them. And I usually have like, you know, that's one of the questions that they ask. Like, I was told I can't have it because of my migraines. Now, I can't give medical advice during the meet and greet, but I just give them a general statement. Like the general statement is not all hormones are the same, yada, yada, yada. But I see, you know, in my new entrepreneur hat, you know, I do a lot of community events and talk to a lot of women. And I see it frequently like, they have brought up statements that I may not necessarily agree. I don't think it's rooted in science, but you know, I can only say so much.
Right.
And then, you know, and if they don't believe me, like that's okay. It's not their time yet.
Right.
You know, so.
Yeah. Or it's not meant for them. And then we go different ways.
Yeah. Yeah.
Okay.
Yeah.
Nice. So my last big question is, you've done this for yourself. You know, you've seen a problem in your own life and you're like, I'm going to figure this out.
Still going on, by the way. It's not
never
like
ends. It sounds like it sounds like forever just knowing you after talking now. It sounds like every time you need to learn something about yourself, you're going to try to find a way to like, I'm going to figure out how to help people with this.
Yeah.
But what is, obviously you've made an impact on a number of people's lives and just quality of life, but like at the core, like what's that thing that keeps you ticking? You know, you're running your business, that's exciting, but there's got to be like that thing where when you wake up in the morning, you're like, this is why I do it. Or those moments where you're like, that was pretty cool. I like that.
Yeah. So, you know, I've lived a very, you know, interesting life. Like, I think right now what makes me tick and makes me like keep going is I firmly believe that God has a plan for my life. And I firmly believe that he has an amazing plan for me. And I just have to take that next step and next step. And at the core of that, he has a plan for me is the fact that one of the side plans for his big plan is for me to help people. Like literally there's a reason why I exist, you know? And I know that sounds kind of cliche or whatever. But
no, it's,
you know, it like we really only live one life and I want my life to be a life of impact, not just for myself or for my family, but just, you know, just changing other people's life, nothing can be better. Nothing can be more rewarding than that.
Yeah.
I have gifts that other people don't have. How can I use this gift to make other people's lives better?
Yeah. And removing like the business side of it, just knowing, I mean, because you have to make a living. You got to buy food, you got to pay your bills.
Yeah.
But like removing that part of it where it needs to be transactional and just getting to the core of like, I sent this person's life on a different trajectory because they came into my office. Like that has to be so rewarding when you see that, like where they came in at and where they're leaving. And they might not always leave right away. So I'm sure there's a wind down, like maybe there's not, but is there like the life cycle of that patient? There's a lot of work and then they get to a point where they are more comfortable and then there's like more of a maintenance, like you see them regularly.
Yeah, I do have a maintenance.
Not as much.
Right. I do have really my kind of plan is, high intensity in the beginning, learning skills, or in the case of hormones, like trying to figure out which one works for them.
Yeah.
But there is a maintenance phase where I see them less often. So they can be with me as long as they want. That's
got to be amazing though, even though you're not seeing them as often, when they get to that point where they're like, hey, I'm happy now, I'm comfortable. And then you see them graduate kind of to that maintenance plan and living a different life. That's got to be like,
it's the best.
That's so awesome. Yeah.
It's the best. Like literally, I mean, again, I always say I transform my life. Like what I teach my patients is literally what I use in my own life.
Yeah, you've practiced it before you, and I'm sure you still see stuff where you're like, okay, like we got to figure this out. It's different. I've not run into this because everyone's different.
Yeah, of course, for sure.
But that's got to be fun too, because you're like, every person's kind of a puzzle and you got to figure out with your knowledge and expertise, you got to figure out how this puzzle works.
Yeah. Well, to the best of my ability. Yes.
Yeah. Well, I mean, but that's different too. It's like you're better at those puzzles than I would be. That's why they're coming to you though.
Oh, yes, for sure.
That's what I meant. Like in your expertise, like you wouldn't come in here and be like, all right, well, let's run all this equipment.
Right. Yeah.
Because, those guys are behind the camera here. That's what their expertise is. So I just meant using your skills, like, you're best suited for that type of puzzle.
I love it. Yeah. And I think it's because I love doing it.
Yeah.
That I think it translates to just, yes, I love puzzles in a way. It's lifelong learning. Yeah. Really, it is.
And you can carry that into the next patient. And every time you
and I learn from my patients, actually. Yeah. I learn from my patients what worked for them, what didn't work for them, or how to improve my practice and just.
Well, and I'm sure you get close with them too. Like they become more than a patient. Like you are invested in them. Like this is your work with them.
Yeah.
So that's awesome.
Mm-hmm.
Anything else you wanted to cover?
No, I think we've covered a lot. Just again, you're not broken, I think is the one thing.
Yeah. That's a good message.
Yeah. If you're struggling with weight or struggling with the symptoms of perimenopause and menopause, it's you're not broken. There's a reason why this is happening, and there's a biological reason that this is happening. And I think you just need to find the help that you need, whether with me or somebody else. That,
do you ever work with other specialists as well, where you're like, okay, maybe it's something that you need, some counseling for, or maybe we have to figure out some other issues too. Like, do you have a network or some?
I certainly do. Yes.
Some other cards in your pocket where you're like, we're going to team up with this person and we're going to kind of boil that down, figure that out.
Yeah. So I've actually been in my practice. One of the things that my patients have access to are special pop-up events that once a month. So like the other month, we did a pop-up event with a sex therapist. And what's coming in June is one with a pelvic floor therapist. So which are all local people, which again, those are all things that a patient may or may not need. So I think it's all congruent.
And you don't offer it, but then they're not competing with you. You're just bringing in more services to help them.
Yeah, but I also work with patients like PCPs. Like I always tell my patients, like, I'm not a primary care doctor, I'm a consultant. And then I work with their primary cares that want to work with me.
Yeah, you have to go here for that, or they refer to you.
Yeah, even 100%. So. Which is interesting. A lot of my patients are mostly self-led. Like they come to me, their own.
When I'm sure it's
direct to consumer.
They're finding you online and through their own research.
or my
Or
patients.
referrals.
Yes,
Yeah.
yes, my own patients. Yeah.
Yeah. Like when they dragged their husbands in.
Right. Yeah.
No, I appreciate you coming in. I'm sure we could talk for hours too about
I
that.
totally can talk
all of
for
it.
hours about this. Yeah.
And maybe we have like a specific update, like if there's a time of year where, there's months for all these sorts of awareness campaigns, but maybe if there's something where you want to talk about a specific part of it and we want to dive into something deeper, we can have you come back on and definitely chat. So
Yeah, menopause month, perimenopause month. I think it's like September, October.
well, maybe we can do a special episode on that. So
love to come back.
awesome. Well, thank you for coming on. I appreciate it.
Well, thank you so much for having me. I appreciate it.